away.
Thanks, Becky, and thanks everyone for joining us today. Our topic today is empanelment, metrics and dashboards for residency. Before we get started, I'd like to introduce myself. My name is Joanna Mizener. I'm the residency program manager for family medicine at West Virginia University School of Medicine. I've only been in the role for just a little under 2 years, and I'm learning more every day. So this project was helpful for my learning as well. I hope it will be helpful for yours. And I am grateful to have a very supportive program director, Dr. Erica Bodkins, with me today, who has helped me to learn and grow my skills as a residency program manager. So I will turn that over to Dr. Bodkins to introduce herself.
Hello, everyone. I'm Erica Bodkins. I'm the program director for the West Virginia University Family Medicine Residency Program in Morgantown, as Joanna already stated. I've been with the department for 10 years, 13 if I count my residency, and I've been involved with the residency program for about 8 of those 10 years. Empanelment and monitoring the metrics for operations has been something that I really was interested in when I took my role of involvement with the residency program. And so we hope that some of the things we're going to share today you find helpful, and really want to leave time open for discussion and maybe learn some things from you all today too. So that's it.
All right, with that, we will begin. Our agenda for today, we're going to start by just grounding ourselves in some key metrics that we're all interested in tracking. So resident-sided continuity, patient-sided continuity, our special population panels, and time in the family medicine practice. Once we define those, we'll talk about panel management, about the size of our panels and how often we need to balance them. And then I'm going to turn that over to Dr. Bodkins for a little bit of talk about building a dashboard for your residency. What are we counting and how can you find the data? And then we'll open that, as she mentioned, for a lot of discussions and questions from you. To get started, we want to talk about continuity. When I started, I didn't entirely understand the nuance between patient-sided continuity and resident-sided continuity. And these are two of the most important metrics that we are going to track on our dashboards and for ADS. Continuity is represented by the green overlap between the total patient visits that your resident has completed and the total clinic visits for the resident's panel patients in the given time range. The difference, resident-sided continuity, you can think of it like this. When your resident is working in clinic, how often are they seeing their panel patients versus seeing someone else's patients that they may not know? And when you calculate that, we're going to be calculating the number of visits the resident had with panel patients divided by the total number of patient visits completed by the resident in the time frame, and then multiplying by 100 to get your percentage. The flip side of that is patient-sided continuity, and that's the percentage of clinic visits that the resident panel patients have with their resident PCP. So think of it from a patient's perspective. When I book my appointment, how often will I see my resident PCP rather than being seen by someone else that I don't know? To calculate that, we're going to look at the number of panel patient visits with resident PCP and divide that by the total number of patient visits with any provider from those panel patients, and then multiply by 100. And then, of course, you have your special population groups. You have your pediatrics, which is 18 and under, and your geriatrics over 65. So now let's talk a little bit about panel management. Panel management can refer to several processes from a population health or patient care perspective. But from our residency program perspective today, panel management is reviewing your resident panels, taking note of the breakdown of age groups, resident and patient-sided continuity balance, and actively working to correct any deficient areas or metrics. This can be done by thoughtfully reassigning patients from your graduates to a resident who is still building their panel. And you can work with your outreach coordinator or clinic schedulers to direct new patients in certain populations to residents who are building their panel in those areas. Additionally, it's very important to periodically review and prune patients from your resident panels who are not coming in regularly for appointments. There's no firm definition given for an active or an inactive patient, but most clinics have a threshold between 18 and 36 months where the patient will be considered to be inactive if they've not been seen. Leaving inactive patients on your resident panels can cause the denominator in your calculations to be artificially large, skewing your calculation for panel percentages. Inactive patients offer no educational value because your resident isn't seeing them in clinic. And for perspective, what your threshold is very important. So a 36-month threshold is the entire length of a family medicine residency. With an 18-month threshold, your resident PCP might only see the patient twice unless acute visits are added. I'm going to take a pause at this point and turn over to Dr. Bodkins to add a little bit of background on how our clinic prunes and defines inactive patients for the purpose of panel management.
So as Joanna correctly pointed out, the ACGME, while we have very strict focuses on percentages of the patient panels that should fall into these special population categories, they don't really actively define consistently what continuity is in terms of the minimum amount of times a patient would need to be seen in your practice or by their resident in order to be considered continuity, or for how long they could not see that resident and still remain on those panels. We have tried different things on for size as a residency program throughout the years, and what we landed on was we defined continuity as 1 year, because then looking at family medicine residency over 3 years, a resident would provide continuity to those patients if they saw them only for their wellness visits 3 times or 3 points of contact through their residency program. While that seems very strict comparative to CMS's definition, which is up to 3 years for a family practice, from a billing perspective and a compliance perspective, you really have to drill down as to what works for you and your program. We don't automatically remove patients who haven't been seen for a year, but that's when we really focus on asking the question, is this person still active with this resident? Is it time to conduct some outreach to get them involved with their resident physician and to provide that continuity? So that's our definition of continuity, taking that into context when you see some of our metrics in our dashboard.
And then we want to talk a little bit about the size of our panels. So how big is too big and how small is too small? Again, there's no firm number given that's required, and you can balance a panel of any size. For example, a panel of 10 patients with 1 pediatric patient and 1 geriatric patient would technically be balanced for special populations. So determining how big is too big and how small is too small should really be viewed through a lens of patient care and educational experience. Is the panel too big for your resident to have enough clinic appointments to see their panel patients when they need to be seen? If your resident can't see their patients when they need to be seen, patient-sided continuity will suffer. Is the panel large enough to provide the necessary volume, depth, and diversity of experience for well-rounded training? If the panel is too small, educational experience will suffer, or the resident will need to see patients outside of their panel for the volume and experience, causing your resident-sided continuity to suffer. So again, I've heard it already in my under 2 years of experience said many times, the clinic is the curriculum. And then, of course, we're always asked to track the time in the family medicine practice. There are lots of ways that you can gather this information on hours spent in your family medicine practice. Some of those options might include schedules or calculations from your scheduling software. They could be your residents' hour logs. or your budget control sheets. What's important to remember when you're calculating your time in the family medicine practice is that you shouldn't double count to meet more than one requirement. For example, if your residents see geriatric continuity patients at a residential facility, these can't be counted as time in the family medicine practice if they're already being counted to meet the requirements of care for older adults. Before I turn the presentation over to Dr. Bodkins to talk about building your dashboard, let's take a minute for some audience participation. Go ahead and put in the chat a few of the items that were required to count that should be a part of your resident dashboard. I see visits with pediatric populations. Good answer.
Can't see anything.
Hours, clinic continuity visits, visits with geriatric population over 65, patient satisfaction, newborns, weeks in the continuity clinic. Yes, that one is definitely on ADS. Emergent care visits. In addition to what we're required to count and track for ADS, which would probably be excellent options to include on your dashboard, you can also make it your own. So what are some ideas of things that you could count that would be meaningful for your residency program or for your residents to track their progress that you might also want to include on your dashboard? Go ahead and put in the chat a few things that you think you could track that would make the dashboard your own. AVFM points, deliveries, yes, continuity and vaginal deliveries. I know for our program, we track didactic attendance. You could also track scholarly points. Resident projects, excellent. Quality metrics, attendance. Great answers. Okay, oh, procedural requirements, modules, lots of great ideas. Now I'm going to turn the presentation over to Dr. Bodkins to talk about what we've chosen to include on our residency dashboard and how we can find that information.
Okay, thanks, Joanna. So, of course, a lot of data that is predominantly highlighted in our dashboard are what we have to enter into ADS and or components of that data to create the formulations. So, of course, we have to track the resident patient panels, both in their entirety as well as for the special populations. Inpatient resident encounters, because those are the ones that still have those finite numbers. You have to meet 50 PD, ED, PEDS encounters, for example. Total resident clinic visits. This is important because that's how we break down that resident-sided and patient-sided continuity. If you remember, if some of you were managers back whenever we had to track a total of 1,650 resident clinic encounters as a requirement from the ACGME, of course, they've gone away from that, from a metric that we have to enter into ADS. And now it's the hours or the weeks in the family medicine practice. But for some of our core faculty, me included, as well as some of our residents, they like to know where they fall in terms of total kind of patient encounter impact over their 3 years. So we've kept that on there. And then visits with a special population. So visits with the elderly population, and then other metrics like Joanna mentioned, didactics. You'll see on the next slide that our dashboard from its 30,000 foot view is very overwhelming. So we actually give them a separate dashboard that monitors their procedural counts for the month. So this is, like I said, that 30,000 view of our resident dashboard. We included it not because you can see anything written on the screen right now, but because it kind of captures the complexity of what you all and we are tasked with providing for metrics to the ACGME and how complicated it can be. And also gives you the viewpoint of what our residents see each month. So we have a method that about a week or 2 weeks after our block, so we have our rotations are 4-week blocks, after our block rotation ends, Joanna and I sit down, run different reports that get populated into this dashboard that gets circulated to our residents. It helps them to stay on track, to realize where they are with their metrics. It also helps us as a program to keep on track through the year, because what we found is that if you don't keep this view in mind, that you might be coming toward the end of the academic year and some of these metrics such as resident-sided continuity or patient-sided continuity might be lacking, in which you can take the opportunity to get back on track before you're required to report maybe some metrics that are subpar to the ACGME standards and ADS, and save yourself some concerning results. So to drill down a little bit further, and hopefully a view you can kind of capture a little bit easier, this basically shows, and I'll just kind of walk through each component of the dashboard and key areas to think about as you're building them. So obviously, if we've used a third-year resident here as this example, it's important to carry through the balances from the previous years. Not so much from a continuity perspective, that doesn't total into those metrics at all. But obviously from a patient panel perspective, that's important, as well as the subcategories that still require minimums over a 3-year period for graduation, such as visits with older adults, or the breakdown between adult inpatient, adult ED, pediatric inpatient, pediatric ED encounters. You can also kind of see in general where they ended their second year, first year in terms of total numbers, which is helpful from their perspective as you're tracking things. But basically along the top there, you can see that each month we run their continuity panels. So our electronic medical record system is Epic. However, I know that there are similar ways to run reports out of other EMRs, but we use Epic and a report that comes out of Epic. And basically, for our residency program, our residents have continuity panels, which I know might not be the case for everyone. Some residency programs focus on team empanelment, which you could still run reports on. But these basically are patients who have our resident physicians listed as their PCPs on their chart. And then that report obviously breaks it down to those that are under 18 or those that are over age 65. And then it spits out the percentage in the third chart to the right of the screen that shows those percentages that need to be over 10% respectively. Coming on down, you'll see that there are cells that include total continuity panel visits. So that is also a report from Epic that gets spit into a secondary reporting system called Tableau. We run it either way. For those of you who have access to those similar systems, that's how we generate our data. And we just pull that report and dump it into a sheet in the background for any patients that we're seeing in our practice that had a resident physician as their PCP, that counts those and for that time frame and puts it in the cells for July, August, September, just October across the screen there, and totals throughout the year. And then, of course, that nice green overlap that Joanna highlighted in the first slide, obviously that's where the numerator comes from. So if they see their resident physician as well as, you know, are seen in our practice, then that counts for our numerator and gets counted in that patient-sided continuity. The same is true for any of our resident visits that happen, regardless of how many are not with their patients. There's a report that we run that calculates that for those individual cells. She's already highlighted the importance of strategically thinking about your dashboard so that you are not double dipping and having to explain that to the ACGME. But we get a lot of our visits with the older population from covering a long-term care facility for where our residents are assigned. They see their continuity patients there. So each block, they have a panel of patients that they're responsible for going and doing their monthly physical on. So for example, that would count into their patient panel metrics at the top for older than 65. That would also count into the patient-sided and the resident-sided visit metrics that would spit out for that block. But it does not count into the visits with the older population. We save that because we don't want to do that double dipping. Fortunately for us, we are still able to meet those metrics because they might see adult patient or patients in that setting that are not on their panel for empanelment whenever they are assigned to be on that rotation as the resident for the month that covers all the acute visits and all the concerns of patients in the facility in general. So that's really the top part there that captures all the ambulatory or geriatric metrics. And then we simply break it down to the inpatient encounters. Again, that's obviously a report that comes out of EPIC, and we put the ED and adult patients into different buckets depending on the setting in which the resident writes their note. So obviously, if they're on a inpatient service and they're writing those notes in EPIC, you can tell EPIC to generate a report to count that visit or that encounter into the admitted inpatient bucket. And then if they see the patient in the emergency care setting in EPIC, then that would count for the ED bucket. So you can literally filter into the buckets that you need to drive those encounters into. And then, as Joanna pointed out, we keep track of our didactic attendance so that a resident knows if they're doing well with that metric or not, with our expectation being that they attend didactics more than 95% of the time in a block. So I think that was it in terms of breaking down our dashboard.
Joanna, there's a question on the chat.
Okay, the question is, do you have the resident log as the PCP or the resident PCP ? So I believe this is an EPIC. Is that correct, Dr. Bodkins, that they identify themselves as the PCP for the patient?
Yes. So in EPIC, there are different ways and there's different PCP assignments. So they are listed as a primary care provider, but their title underneath that is resident. The different options under that as well that different programs use is that sometimes you can put them as the managed care primary care provider or part of a team. But we keep it simple and just stick with them being listed as the primary PCP with a resident kind of subgrouper under that. Why we include their identity as a resident is because sometimes the argument for a team-based empanelment is that residents cannot be the primary care providers for certain insurances. That's not exactly the case. You just also have to list a faculty member. So in that perspective, we keep the resident listed as a primary and then the faculty member who's listed as insurance coverage or care management PCP, and it keeps it cleaner for us and how we monitor things if we take that approach.
Megan, did that answer your question? Yes, thank you. All right, so we're going to transition to our next slide. How often should we balance our panels? As we mentioned, our program has determined that monthly is about what we need to do. Sometimes we hit it a little more, maybe a little less right around the turn of the academic year, as there's a good bit of setup that is required to transition the dashboard from one academic year to the next. But we find that works really well for us. How often is not a firm rule for everyone. So that's really up to you. Just give yourself time for that course correction if needed. And then to review, this is my top 5 for reasons that you may want to keep a residency program dashboard. Number 5, course correction. Counting, reviewing, and balancing as you go allows for necessary course correction before you're in a pickle. So you want to give yourself time to look at those numbers, see what they're trending, and make appropriate adjustments. That might be to how often your residents are in clinic, or to helping them build their panel in certain categories, but you want to give yourself time before it's time to report. Number 4, keeping a dashboard will save you hours of digging at the end of the academic year when things are already busy. There's so much we're required to do to end one year and begin another, and there's really no time in between. So the last thing you want to do is add a lot of data digging to that timeline. So keeping a dashboard throughout the year will save you hours in the summer, and then you can have a little more time for summer fun. Number 3, capturing and sharing dashboards with your residents is a great way to help them measure their progress, and it allows them to be an informed participant in their clinic and educational experience. Number 2, keeping a dashboard is a concrete reminder that your program is providing a high quality training experience for your residents. And finally, the best reason for keeping a dashboard is because we're required to report on this. So if you have to report on this and you have to track it, you might as well make it great. And with that, I will turn it over to the chat for your questions and discussion items about metrics and dashboards. I like the pickle icon from Rebecca. Do we have any questions?
Feel free to unmute yourself and go ahead and ask if you don't want to put it in the chat.
Okay, we have our first question from Kristen. Our hospital is about to switch from Cerner to Epic. Do you have any advice?
I think it's important for you to probably meet with someone from IT, you and, maybe even other leaders in your residency program or program director. Whenever we started running reports, I knew a lot about it from my other roles in the department, but it is helpful to meet with somebody in IT who's in charge of building reports, or at least is a point of contact in the Epic system for your program, because you can even work with them to create the reports, and then they can spit the reports out automated and they get emailed to you every month. So it might take some of the burden off if set up correctly from the beginning. But my only other advice is there's about 1,000 ways to do things and reach the same goal in Epic. So helping to boil that down through a discussion is better than just kind of maybe finding your own way.
I think the only thing I would add to that is consistency is really important too. Like once you decide how you're going to pull it the same every month, so that you make sure that you're getting clean data. Megan Coles has a request. Do you have a clear view of our dashboard that we could screenshot? And I can include that with these slides that we will release to the group. It's really hard to get a clear view of that on a slide, but we can definitely send you something that's clearer. When rebalancing patient panels, how does the reassignment of patients affect panel metrics? That's a really good question. Dr. Bodkins, do you want to address that one?
Yeah, we always try to make it in the positive. However, that's not always the case. So rebalancing for our program happens usually at least quarterly as we're coming down to the end of the year. We might do outreach even more aggressively than that on a monthly basis. But basically what we have learned as a sweet spot is that when we rebalance patients, we try not to rebalance them to a third year, an upcoming third year resident. Patients don't love that if they are having to be rebalanced or reassigned or pruned, whatever term you want to try to make it positive about, and be on that kind of hamster wheel every year. So when we rebalance or we reassign with residents that are graduating, we really focus on taking those third year resident panels and shifting them toward incoming first year and upcoming second year. That way it positively affects that continuity. The patients appreciate that better, and then that gives you time to course correct and do outreach if they're not coming in to see their new PCPs.
All right, so from Courtney, great presentation. Thank you, Courtney. We appreciate that. We were told recently that Epic built a report for all programs to use, but we have not seen it. They mentioned this at RLS last year. Has anyone used that report? And if so, was it accurate? That one, if anyone has experience with that and you want to put that in the chat or come off of mute, that would be great. Dr. Bodkins, have you seen that report?
I also heard mumblings about that. I have not seen the report. I also, full disclosure, have not looked for it, only because what we do over the last 2 years, we've kind of gotten down to a pretty finite science. So I do know in general, there are ways pre-built into Epic to focus on continuity. I have not seen it spit out something that's pretty comprehensive in terms of everything that you would be asked in ADS. And then of course, nothing that would be something that you would individually want to track for your program didactics as example for us.
The instruction from the ACGME RLS helped us to build the dashboard in Epic. All right, so another comment, I've not seen the report. It will depend on how your version of Epic is structured. You may need to ask for certain builds or security to get them. Do you have a comment? Thought I heard someone. All right, so what are the challenges that you have with metrics, or I can open up a discussion item I know that we are actively working through all the time is what to do with off-cycle residence metrics. Epic is like speaking a different language for me from Courtney.
Yeah, Courtney, I would agree. And even if there is something, again, that Epic is working on, it really does depend on your version of Epic. It also depends on being able to find it easily. I know that my view is as a physician is very different than Joanna's view and Joanna's access. So I would really come back to meeting with your IT administration and Epic, and if there is something that's uniformly available, working with them to create it to make it your own.
Do you have any more questions or challenges that you want to discuss? Is there any written instruction you could share on this? And yes, there is. And what we have a tip sheet, and I still use it every single time I pull data into the dashboard. When you create your dashboard, you will also need to create your own tip sheet that goes along with it, because the way that we pull our data and incorporate that might be different for you, or you may choose to track different things. As Dr. Bodkins mentioned, we see a lot of, or our residents see a lot of patients at a geriatric facility. You may not have that as a part of your program, but I can definitely share with you our tip sheet so that you get an idea of the level of detail that we've included in that to help us get that clean, consistent data. Tip sheet would be amazing. It is very helpful. All right.
We could also probably, it's a relatively big file, and I'm not very tech savvy, honestly, with that kind of stuff. But Joanna could probably also share our foundational, like not the one that has our resident data in it, Joanna, but our kind of template of our dashboard, so that you can kind of work through that as you're looking at the tip sheet, because the two together really would make a difference for launching something that would be successful for you.
We can send those both out with the slides. So how about, oh, go ahead. Deb Canfield, I think, has a question.
I actually have a comment. Going back to the talking about the report in Epic, I've never seen a report that Epic created, but I do have a handout that was done by a physician clinical informatics that's specifically for family medicine, and he wrote out how to write the reports yourself in Epic, and whether you need to go to reporting workbench or slice and dicer, and which security access you would need. I could probably share that with you if you want to send it out to the group. It's pretty long, and there's a lot of information in there, and some people can use it, or some people can do it because they have all the access. For instance, I'm not able to do the inpatient stuff, but my program director is, but I can do all of the clinics. So I can send you that, Joanna, if that would be helpful for other people to get copies of.
I think that'd be a wonderful thing to include with our resource packet for this presentation, because everyone is going to have some different ideas and tips for Epic, different levels of access. That would be great. Thank you.
Sure.
I'm kind of curious to poll the group. Do any of you struggle with the challenge now, especially with the new ADS system of off-cycle resident reporting and metrics? I know for us, that's one that we're actively looking at currently.
This will be my first year with an off cycle or somebody who left early. So I haven't had to calculate like what's going on yet, but I'm sure it's going to be super fun.
We have a number of off-cycle residents, and so that definitely changes our workflow for the annual ADS update to updating when they graduate, in addition to the annual update to make sure that the case logs are closed. This is an ever-evolving process. We had one last year and had to contact the ACGME a couple of times before we felt secure in what we were doing. Yes, I would echo our feeling as well. We have just a few more minutes. If anyone has any questions, if not, we can give you a little bit of time back in your day. Thank you so much for joining us today. And we will send all of those. Oh, one more question. We'll send all of those resources out with the slides. The last question here is, do you input the case logs for all your residents, or do you have residents input it themselves? We input data for our residents. Ours do not currently log into the ACGME site to do case logs. We do have them tracking their procedures and their hours in a system called eValue, which I'm sure many of you no longer use in favor of New Innovations or MedHub. But we take data that they enter on those, and we put the information into ADS. You're welcome. All right, I think, Rebecca, we're turning that back to you.
Somebody wants your email.
I will send that. I'm going to stop sharing my screen here so that I can add that to the chat a little more easily. Thank you again for being here.
All right, guys. Well, I just wanted to kind of put a plug in. Of course, thank you so much, you guys. This is amazing. Wish we would have done this sooner. I'm so glad that Joanna and Dr. Bodkins could join us today with this information. I know it's something that we all kind of struggle with every year. Next week, I believe it's next week, February the 9th, our webinar will be on from the NRMP. So it'll be a trainer telling us, you know, how to do everything in the NRMP, get our rank lists and everything set up. So that, you know, we're prepared for when we need to submit everything. So join us on the 9th also. Oh. Joanna, were you going to add that stuff to the chat here in the Teams, or were you going to send it out on a listserv, or how were you going to disseminate that information?
I think it would make most sense if I package up the slides and also the shell of the dashboard and tip sheet and send to you. And then I think Deb is also going to send an item. She can send Deb, if you could send that to me and copy Becky on that as well, please.
Okay.
We'll make sure we get it all packaged up for the group. Thanks.
All right, I'm adding my email address here so that you can send it to me also if I could just learn how to spell today. Okay. So I will add it to the chat so that anybody that was live on this chat will be able to access it through the chat. Because this will stay in your Teams, but I will also share it on the listserv and I will try and get it. I'm going to upload the recording that we have to our YouTube channel. And then I will also see if I cannot get all of the slides and the other resources uploaded to the AFMA website so that it'll be there kind of forever so that you guys can access that. Now, if we have updates to any of this, I know Joanna's going to let me know, and we're going to do another webinar at some point. So I thank you so much. We're going to close out and give you like 13 minutes back in your life. If anybody has questions, you can reach out to me or Joanna, and our emails are in the chat. All right. Thanks, guys. Have a great rest of your day.